Good afternoon, good evening, good morning, students. It's Paul from Australian Paramedical College, going through the theory side of cannulation. And I want to preface this by saying that part of our ethical standards is at first do no harm. So make sure that we go through this process correctly and make sure that we don't introduce foreign bodies, foreign substance to our patients. Very, very important. So let's get going. I'm pretty sure you can all see that screen. Peripheral IV cannulation introduction. And I'll just start clicking around to make sure. Okay, so learning objectives of the course is to identify veins suitable for cannulation, state precautions which to reduce risk of contamination and improve safety to yourself and to your patient. Identify complications of IV cannulation, their treatment and their prevention. Demonstrate preparation for venous cannulation. And insert a cannula using an aseptic technique. Disclaimer. Okay, so many people will train this in different ways. This is one way I've been teaching for quite a while now. And from a theory side of it, it's a good systematic approach, which if you learn, it makes the whole job so much easier. Indications for cannulation. So what are the indications? To maintain hydration and or correct dehydration in patients unable to tolerate sufficient volumes of oral fluid. Administration of drugs, iron infusion, transfusions of blood or blood components, contrast for radiological studies, and then we get on to the veins themselves. Okay, so which ones do we usually use if we're, if we're putting a large bore cannula into anyone? We tend to look for the basilic or the cephalic vein, and obviously in there we've got the median cubital vein as well. Landmarks. Good people who have been doing this for quite a while have a very good understanding of the landmarks of that area, and I've seen people cannulate patients where, well, we can't see a vein at all, but because they know where the landmarks are, they're very they're very efficient at being able to cannulate in the correct position. Going down to the hand, we've got the basilic veins down there, metacarpal veins, cephalic veins, and the dorsal venous arch there as well. Yes, again, we probably, part of our strategy is to, start distally, depending on what sort of medications we're using, and then work up proximally. So we tend to start at the hand if it's indicated, and then unfortunately, if we're unsuccessful, then we can move further up to the antecubital fossa there. Now, characteristics of a good vein, and they're all good veins. I wouldn't even need to put a tourniquet on there, because if we miss that, we're in trouble. Okay, they're bouncy, they're soft. It refills when depressed, visible, it's straight, it's nice and large, it's well supported. Okay, how do we encourage venous filling? We reassure the patient. We apply tourniquet. Ensure you have a distal pulse. Okay, this should not take us longer than 2 minutes once we have put a tourniquet on. Ensure easy access to release. Clench and open and close your fist to encourage venous filling. Tap the vein lightly. Some people have been doing this for a long time, have their own techniques that work for them. If you do this on a regular basis, you'll find your own. Allow the arm to hang below the heart. And one that I use a lot is a warm compressed towel or face washer. Then we can just warm it up, and it tends to work really well. Selecting the site. And as we discussed before, we've got the cephalic vein, the median cubital vein in there. And again, it's all about learning your landmarks. So without sort of sitting here teaching you where the veins are, people need to have a good understanding of where they're trying to select, and then have an understanding of the landmarks around there and the veins. Always allow adequate time for inspection and palpation. Do not race this unless it's indicated that we need to do it very quickly. Take your time. Talk to the patient. Distal vein should be used first, with subsequent venipuncture proximal to previous site. So as discussed before, we can start at the hand and move up from the wrist, and we can move up the arm from there. Use opposite side for cannulation to any surgical procedure, very much in hospital related, this one. And try to use the non-dominant arm if possible. Just ask them, are they left-handed or right-handed? Areas to avoid. Veins that are thrombolyzed or fibrosed, inflamed or bruised, hard, thin or fragile. If they're mobile or tortuous. So unfortunately, some people have all these and they're very hard to cannulate. Areas of joint flexion we definitely want to stay away from. Veins close to arteries, veins that may be irritated from previous use, areas of infection, injury, phlebitis, edema. Additional considerations: patient's age, patient's activity level, veins location and condition, type of solutions to be administered, and flow rates. Very much a in-hospital understanding there. Duration for the device that the cannula will remain in place. A lot of it obviously from a pre-hospital point of view. We don't take into consideration that too much, but if you're out on site, you may have to have some there for an extended period of time, so it's something to think about. Type of procedures or surgery that's anticipated. A cannula must never totally occlude a vein. Okay, what equipment do I need? Okay, obviously we need cannulas, and we can go through the charts there. The orange is a 14 gauge. Okay, so as the gauges go up, they get smaller. So 14 gauge, I'm looking for rapid infusion of blood, multi-trauma and epidurals. 16 is very similar, and as you see there, the flow rate, that what I can put in per minute is alongside there as well. For us, we tend to use our 20s and our 22s, again 18s, and for our PDs and neos, little tiny 24 gauge. Okay, keep moving. Next. Okay, so come back to at first do no harm. Let's look at our infectious control. Okay, 5 moments of hand hygiene before we approach the patient, immediately prior to cannulation, following cannulation. Okay, we want to use gloves and eye protection if required. Preparation, and this is where you win. This is all in a systematic approach, so just make sure that we follow this every time. Even when we're practicing our cannulations, we want to do this in a systematic way. So we just don't want to pick up 20 cannulas and start throwing them into a mannequin. We definitely want to go through a systematic approach. Consult with the patient, explain the procedure and why. Get a patient's consent. Positions the patient's arm and the patient for their comfort Identify any health and safety risks to your posture, so you want to be in a good position to be able to do this. Check for contraindications, allergies. Okay, we want to make sure that, you know, local infections and fistula, so AV fistula. So again, we've gone through those contraindications in the previous slides. Check for any additional tests or requests to be performed at the time of cannulation. Again, more in hospital, so we may be taking bloods for doing some blood tests. Okay, the procedure, and look, we'll run through the procedure because this is a skill that you'll learn more than likely at your residential school or when you come in and you actually do it on the mannequins. Wash your hands, prepare your equipment. You must prepare the equipment, place it in order of use. Okay, and I live by a rule of twos. Make sure you have 2 of everything, because if you do fail it, you don't want to get up and repeat everything and go and get stuff and reset the patient and so on and so on. So usually I'll find that most people will have 2 goes, and if they fail at that, then we need to get someone else to have a go at cannulating. Maintain aseptic technique throughout. And most people who fail this, from a practical point of view, don't follow that. At some stage, they make a mistake. And they're picked up and they'll go through the process again. Position the patient. Ensure the position is stable, maintaining good posture. Use alcohol-based hand rub. Apply your tourniquet 15 centimetres above your cannulation site. So yes, if I am doing the wrist, I want to make sure that it's only 15 centimetres above that site. Check for distal pulse. Do not leave it for more than 2 minutes. Palpate the vein. Okay, and then the procedure. Again, from a skill and practical point of view, you'll do that when you're in residential school or when you're doing this course. But we'll go through the procedure anyway. Put on your gloves, eye protection if required. Rip the skin from center out, and we've probably done that many times. Allow to dry. And a big no-no, don't retouch. I think I've done that. Yes, do not repalpate the clean area, because you'll just have to clean it again. Are we using a local anesthetic? As the better you get at this, and again, it's all hypersensitivity to needles and patients' reactions. We may need it in some cases, but most times, if you're doing it correctly, it doesn't hurt that much. Uncap the cannula and unlock and rotate. So we want to make sure that the cannula can slide off very easily. Technique, again, many people have different ways of holding a cannula. Many people have issues with one cannula compared to another. Just make sure you get used to what you're doing. Okay, as we can see there, we've picked our site. We're holding, and we'll go through this technique here. Okay, hold the cannula in the dominant hand and use your free hand to pull skin tight or taut. Anchor the vein, so we want to keep it nice and still. Prevent the limb from flinching. Discussion, communication with your patient is paramount. Do not retouch any area. Okay, the technique, and when we're doing the practical, I mean, that's what we're trying to do. We're trying to insert it into the lumen, advance the needle in the lumen, and then advance the cannula in the lumen before we retract the needle. Bevel up, as you can see there as well. Practically, we'll go through this. This is the theory side of it. Insert the cannula until we have flashback. Lower the angle of the cannula and insert a further 2 to 3 centimeters to ensure the cannula is completely within the vein. Advance the cannula completely, keeping needle still. You'll practice this and you will get better at it. Once the cannula has been inserted, Then we need to obviously put a bung on. There's certain things from a practical point of view that I go through, and that's just keeping everything tidy and clean and blood not shooting around everywhere. Okay, so once the cannula has been inserted, we want to release the tourniquet. Occlude the end of the cannula, remove the needle and place in the sharps container straight away. Connect the bung or fluid giving set. We will always put a bung on with our pracs at the college. Secure with tape. Attach syringe and flush with 1 to 2 mils of normal saline. We want to make sure, just draw back a little bit to make sure that everything's correct, and then insert and flush. Apply dressing and secure with tape. Ensure insertion point is visible through the dressing. Date on the tape. Okay, on completion of the procedure, remove all waste, disposal of sharps safely, ensure the patient is left comfortable. Hand hygiene on leaving the patient, or if you're staying there, wash your hands. Documentation. Okay, some of the complications that can happen. Okay, during cannulation, we can have bruising and hematoma forming because we've gone through the vein. We can cannulate an artery. We don't want to do that. So knowing our landmarks is vitally important. We can also, unfortunately, at times, we can cannulate a nerve, tendon, or ligament damage if we're not trained and competent of doing this. You will always do this with a competent person training you. On a mannequin, we have trouble with the nerves and tendons because they're just not real people. But if you're going to cannulate a nerve, you'll find out very quickly. So let's hope you never do it. We have vasovagal reactions, and that's more of a male thing. Females tend to sort of handle this a little bit better than some males. Okay, post-cannulation, phlebitis, extravasation, complete dislodgement, occlusion of a vein, and again, this is at first do no harm. Let's make sure that we do this correctly. So yes, we may miss a vein. We may inject sort of saline into and have an extravasation, but septicemia is just unforgivable. We need to do this aseptically. It is incumbent on everyone to do this correctly. Irritation during injection and infusion. And people can have allergic reactions during injection and infusion, so we need to monitor. Okay, maintaining the IV site inspection, dressing change as required, venous reactions, so we want to make sure we're having a look and monitoring the patient. Careful handling, cannula changed, which again will go depending on your local protocols, and some routinely change at 72 hours, some at 48, but we don't want to keep sticking a patient if we don't need to and everything's aseptic. IV administration sets change every 24 to 48 hours as per your local policy. Removal as ordered. Cover insertion site. Check bleeding is stopped. Okay, and then just some points to remember. Patient consent and explanation. And even before that, just remember your ethical duties. Let's not do any harm to this patient. Prepare the patient and the environment. Inspect, choose your site. Size of cannula appropriate to site and treatment. Make sure that we are aseptic all the time. Safe disposal of equipment. Maintenance of the site. So we want to keep monitoring. So there we have it. I'm going to stop that share. We'll come back to here. Thank you, students. The practical side of this, everyone will go through once they get to residential school. And just go through this a few times so you can remember what the requirements are from yourself. And preparation is so important. Thank you, students, and we'll see you later.